Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to another solid anatomy video. This video is going to cover the bones, muscles, blood vessels, nerves, and viscera of the posterior abdominal wall. Now, I'm going to be back later for a clinical correlation for your end of session quiz, but for right now I'm going to turn you over to our primary lecturer, Dr. John Phelan.
As we've mentioned in previous solid anatomy abdomen lectures, the abdomen is officially located between the inferior thoracic aperture and the superior pelvic aperture. The bones of the posterior abdominal wall are thus the 5 lumbar vertebrae and portions of the hip bones called the ala of the ilia. The ilium is one of the 3 bones that fuses during development to form the hip bone. The ala, which is Latin for wing, is the posterolateral portion of the ilium that ends superiorly along the iliac crest. The area between the ala is referred to as the greater pelvis, or false pelvis, as opposed to the lesser or true pelvis, which is found inferior to the superior pelvic aperture. These bones provide attachments for the muscles of the posterior abdominal wall. If you've watched the solid anatomy lecture on the anterior abdominal wall, you may recall that the deepest of the 3 anterolateral abdominal muscles, the transversus abdominis, takes its origin in part from the thoracolumbar fascia, which arises from the vertebral column. Thus, upon inspection of the posterior abdominal wall, the posterior portion of the transversus abdominis muscle is visible laterally. Medial to the transversus abdominis, taking its origin from the 12th rib and the transverse processes of the lumbar vertebrae, and inserting on the iliac crest is the quadratus lumborum. It is a flat 4-sided muscle that is innervated by direct branches from the ventral rami of T12, L1, L2, L3, and L4. It laterally flexes the vertebral column and extends the vertebral column. Medial to the quadratus lumborum is the psoas major, a long fusiform muscle which originates on the bodies and transverse processes of the lumbar vertebra and passes deep to the inguinal ligament, where it merges distally with the iliacus muscle to form the iliopsoas muscle. The psoas major is innervated by direct branches from the ventral rami of L1, L2, and L3. The iliacus muscle, which covers the internal surface of the ala of the ilium, takes its origin from the iliac fossa and from the sacroiliac ligaments. It is innervated by the femoral nerve, which will be described in a moment. The iliopsoas muscle extends into the thigh and inserts on the lesser trochanter of the femur. It is the strongest flexor of the hip joint. The psoas minor, which runs on the anterior surface of the psoas major, is absent in about 50% of the population on one or both sides. Its origins and insertions vary, but most often it arises from the body and/or transverse process of the first lumbar vertebra and inserts on the superior pubic ramus. The psoas minor receives its motor innervation from a branch from the ventral ramus of L1. It is a weak flexor of the vertebral column. Part of the diaphragm muscle is found on the superior extent of the posterior abdominal wall. The diaphragm takes its origin from the inner surface of the xiphoid process, the 7th through 12th ribs and costal cartilages, the bodies of the first 3 lumbar vertebrae and their intervertebral discs, and the arcuate ligaments. The portions that originate from the bodies of the lumbar vertebra are the left and right crura. The right crus bifurcates superiorly to form the esophageal hiatus. Occasionally, the left crus contributes to the hiatus as well. The right and left crus form the respective sides of the aortic hiatus and converge in the midline to form the roof of the aortic hiatus, which is called the median arcuate ligament. The medial arcuate ligament is formed by a condensation of the deep fascia of the psoas major muscle at the level where the diaphragm overlaps that muscle. The lateral arcuate ligament is a condensation of the fascia of the quadratus lumborum at the point where it is overlapped by the diaphragm. The muscle fibers of the diaphragm insert on its central tendon, which has no bony attachments. The left side of the central tendon is fused to the overlying inferior part of the fibrous pericardium. The diaphragm is the chief muscle of respiration. At rest, the muscle has a double-domed appearance with its convex side pointing into the thorax. During inspiration, the diaphragm contracts and flattens inferiorly to increase the volume of the thoracic cavity. Normal expiration is achieved through relaxation of this muscle. During forced expiration, the abdominal muscles contract to compress the abdominal viscera and push them against the diaphragm, which moves the muscles superiorly to decrease the volume of the thoracic cavity. There are three main diaphragmatic apertures that allow passage of structures between the thorax and the abdomen. The vena cava foramen is an opening through the central tendon just to the right of the midline at the level of the 8th thoracic vertebra. Passing through it is the inferior vena cava, returning blood from the lower half of the body to the heart. The esophageal hiatus, the muscular borders of which were described previously, is found at the level of the 10th thoracic vertebra. The esophagus and the accompanying anterior and posterior vagal trunks pass through the esophageal hiatus along with esophageal branches of the left gastric vessels. The posterior wall of the aortic hiatus is the body of the 12th vertebra. As mentioned previously, its anterior and lateral walls are formed by the crura of the diaphragm. The aorta, azygous vein, and thoracic duct pass through the aortic hiatus.
Welcome back. Let's pause for a moment and talk about some of the anatomy Dr. Phelan's been discussing, starting with the esophageal hiatus. Now, if the stomach escapes from the abdomen and travels through the hiatus into the mediastinum, we call that a hiatal hernia. It can sometimes be found incidentally on a visual study of the upper GI tract, like a barium swallow or an endoscopy. Hiatal hernias can be asymptomatic, but they can also be associated with symptoms of gastroesophageal reflux disease, often called GERD or GERD, which is often called heartburn or acid reflux by the lay public. Now, not everybody with GERD symptoms has a hiatal hernia, but lots of them do. There are different types of hiatal hernias, but the two main types are a sliding hiatal hernia and a paraesophageal hiatal hernia. Now, the sliding hiatal hernia is the more common type, in which the gastroesophageal junction, or the GE junction, and the stomach are both displaced through the diaphragm, so it's sort of an upward herniation of both the stomach and the GE junction. Everything kind of slides upward. Again, this is by far the most common type of hiatal hernia. About 95% of hiatal hernias are these sliding hiatal hernias. Then the paraesophageal hernia is where the stomach protrudes through the diaphragm, but the lower esophageal sphincter does not. So the GE junction remains in the normal location. The problem with the paraesophageal hernia is that it can cause ischemia, which can lead to permanent damage and scarring of the stomach. So that's the more worrisome one. A sliding hiatal hernia is not as serious, but it can increase GERD symptoms. Now, these can be treated with medical anti-reflux agents or with surgical repair of the hernia. And then Dr. Phelan also described the iliopsoas muscle. And I want to highlight this muscle for just a second and its relation to the appendix and acute appendicitis. We talked about this briefly in the Abdominal Organs Part 2 video. If a patient has a retrocecal appendix, where the appendix sort of folds back it can lie against the psoas muscle on the right side. And because of this, there can be a clinical exam finding associated with acute appendicitis called psoas sign. So this is where passive extension of the hip and the iliopsoas muscle leads to right lower quadrant pain. We talked about McBurney's point tenderness in that previous video on the abdominal organs, but here you have a muscle of the posterior wall that is identifying an acutely inflamed appendix by eliciting this psoas sign. Now, a positive psoas sign could also indicate pathology in the kidneys or the pancreas, in the ureters, the cecum, or in the nerves of the posterior abdominal wall, as well as the appendix. So really anything that lies on top of that psoas muscle could elicit a psoas sign. So it's a fairly nonspecific sign, but you should know that the psoas sign is classically associated with an acutely inflamed retrocecal appendix. All right, let's get back to Dr. Phelan.
The blood supply to the diaphragm comes from the pericardiacophrenic and musculophrenic arteries, which are branches of the internal thoracic artery, and from the superior and inferior phrenic arteries, which are usually direct branches from the aorta, superior and inferior to the diaphragm. Occasionally, the inferior phrenic arteries are branches of the celiac trunk. The phrenic nerve, which receives contributions from the ventral rami of C3, C4, and C5, is the motor nerve to the diaphragm. Hence, the popular rhyme, 3, 4, 5 keep the diaphragm alive. Pain fibers from the peripheral part of the diaphragm travel in the intercostal nerves, while pain fibers from the more central parts of the muscle travel through the phrenic nerve. You may recall from the solid anatomy lecture on the thoracic wall that the ventral rami of the thoracic spinal nerves did not combine to form a plexus, but instead remained independent as the intercostal and subcostal nerves. The ventral rami of L1 through L4, however, combine to form the lumbar plexus, which is located deep to the psoas major muscle. You've already seen that the psoas major and quadratus lumborum muscles originate so closely to the vertebral column that they are innervated by direct branches from the lumbar ventral rami proximal to the formation of the lumbar plexus. The iliacus muscle, the lower portions of the anterolateral abdominal wall, and parts of the lower extremity are innervated by the 6 branches of the lumbar plexus that emerge from the lateral, anterior, and medial aspects of the psoas major muscle. The first branches of the lumbar plexus, which are both derived from L1, are the iliohypogastric and ilioinguinal nerves. They often emerge from the lateral side of the psoas major as a single trunk that splits distally. The iliohypogastric nerve runs superior to the ilioinguinal nerve across the posterior abdominal wall. They both run inferolaterally. They pass between the transversus abdominis and internal abdominal oblique laterally, and give off muscular branches to the lower parts of the anterolateral muscles of the abdominal wall, as well as cutaneous branches. The cutaneous branches of the iliohypogastric nerve innervate the skin of the lower abdomen. The ilioinguinal nerve enters the inguinal canal by piercing the internal abdominal oblique and exits the superficial inguinal ring. Its cutaneous branches innervate skin on the superomedial thigh, the upper part of the penis and scrotum in the male, and the mons pubis and upper part of the labia majora in the female. The genitofemoral nerve receives contributions from the ventral rami of L1 and L2. It usually pierces the anterior surface of the psoas major and splits into a genital branch medially and a femoral branch laterally. The genital branch passes through the deep inguinal ring to enter the inguinal canal, where it accompanies the spermatic cord in the male and provides motor innervation to the cremaster muscle and cutaneous innervation to part of the scrotum. In the female, the genital branch of the genitofemoral nerve accompanies the round ligament of the uterus through the inguinal canal, gives off no motor branches, but provides cutaneous innervation to the mons pubis and part of the labia majora. The femoral branch of the genitofemoral nerve passes deep to the inguinal ligament and innervates skin over the upper part of the femoral triangle. The lateral cutaneous nerve of the thigh, or lateral femoral cutaneous nerve, which is derived from the ventral rami of L2 and L3, emerges from the lateral side of the psoas major and crosses the iliacus obliquely. It passes deep to the inguinal ligament near the anterior superior iliac spine, pierces the deep fascia of the thigh to become superficial, and provides sensory innervation to skin on the lateral side of the thigh as far inferiorly as the knee. Medial to the lateral cutaneous nerve of the thigh, the femoral nerve extends just beyond the lateral border of the psoas major and descends between it and the iliacus muscle, to which it provides motor innervation. The femoral nerve passes deep to the inguinal ligament to enter the anterior compartment of the thigh, where it divides into extensive muscular and cutaneous branches. One of its branches, the saphenous nerve, continues inferior to the knee to innervate skin on the medial side of the leg. The femoral nerve is derived from dorsal branches of the ventral rami of L2, L3, and L4. The anterior branches of the ventral rami of L2, L3, and L4 give rise to the obturator nerve, which runs between the medial border of the psoas major and the external iliac vessels, crosses the pelvic brim, and runs anteriorly into the pelvis. It passes through the obturator canal, which is a pathway through the obturator muscles that cover either side of the obturator foramen, and enters the medial compartment of the thigh, where it divides into motor and sensory branches, the latter innervating skin over the medial thigh. Part of the ventral ramus of the fourth lumbar spinal nerve unites with all of the ventral ramus of the fifth spinal nerve to form the lumbosacral trunk, which is found posterior to the obturator nerve. It does not innervate anything in the abdomen, but it crosses the pelvic brim to enter the pelvis and contributes to the sacral plexus of nerves, which will be discussed in the solid anatomy lecture on the pelvic wall. The sympathetic trunks pass deep to the diaphragm muscle to continue into the abdomen from the thorax, just lateral to the vertebral bodies. The right sympathetic trunk runs deep to the inferior vena cava, while the left is lateral to the aorta. As they proceed inferiorly through the abdomen, their course shifts medially, leaving them just anterior to the bodies of the lower lumbar vertebra between the psoas major and the iliac vessels. The sympathetic trunks cross the pelvic brim and enter the pelvis as the sacral sympathetic trunks. While in the abdomen, the sympathetic trunks give off the lumbar splanchnic nerves from L1 and L2, which are described in the solid anatomy lecture on the abdominal viscera. They also give off branches that merge medially to form the superior hypogastric plexus, which will be discussed further in the solid anatomy lecture on the pelvic wall. The sympathetic trunks are retroperitoneal for their entire course through the abdomen. The final branches given off by the thoracic aorta before it passed through the aortic hiatus were the bilateral superior phrenic arteries, which supply the diaphragm. The first branches from the abdominal aorta, upon passing through the aortic hiatus, are the bilateral inferior phrenic arteries, which also supply the diaphragm. The abdominal aorta and all of its branches are retroperitoneal. The abdominal aorta runs along the bodies of the lumbar vertebra to the left of the inferior vena cava and bifurcates into the left and right common iliac arteries at about the level of the body of the fourth lumbar vertebra, which corresponds to the level of the iliac crests. 3 of the unpaired branches of the abdominal aorta, the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, are described in detail in the Solid Anatomy lecture on the abdominal cavity and viscera. The other unpaired branch, the median sacral artery, arises from the posterior side of the aorta at the level of its bifurcation and descends along the midline of the sacrum in the pelvis. The paired branches of the abdominal aorta are the aforementioned inferior phrenic arteries, which usually arise independently from the aorta, but may be branches of the celiac trunk, the renal arteries and middle suprarenal arteries, which will be described shortly, and the gonadal arteries, which supply the testes or the ovaries. The gonadal arteries are called the testicular arteries in the male and the ovarian arteries in the female. They usually arise from the aorta at the level of the second lumbar vertebra. The testicular arteries enter the deep inguinal ring to pass into the inguinal canal and become invested in the spermatic cord, which was further described in the Solid Anatomy lecture on the anterior abdominal wall. The ovarian artery runs to the ovary in the suspensory ligament of the ovary, a peritoneal ligament that helps anchor the ovary to the lateral wall of the pelvis. Branching from the posterior side of the aorta are 4 pairs of lumbar arteries at about the level of each of the first 4 lumbar vertebrae. These arteries pass posterior to the psoas major and usually posterior to the quadratus lumborum as well, though 1 or more may cross anterior to this muscle. The lumbar arteries then pass between the transversus abdominis and internal abdominal oblique and run laterally before anastomosing with any of several arteries, including the inferior epigastric and deep circumflex iliac. You may recall from the Solid Anatomy lecture on the deep back and spinal cord that the lumbar arteries also contribute to the anterior and posterior spinal arteries that supply the spinal cord. The inferior vena cava arises from the coalescence of the left and right common iliac veins at about the level of the body of the 5th lumbar vertebra, to the left of the aorta. As it ascends, the lumbar vertebral bodies and right psoas major muscle are deep to it. The inferior vena cava passes posterior to the bare area of the liver, into which it is often embedded, where it receives the 3 hepatic veins. It then passes through the vena cava foramen and penetrates the fibrous pericardium to reach the heart. Remember that the inferior vena cava does not receive blood directly from the gastrointestinal tract, because that blood drains into the portal vein to reach the liver, where it is cleaned before it is delivered to the inferior vena cava. The inferior vena cava receives the median sacral vein at its bifurcation and usually receives the 4 lumbar veins on its posterior side. The right and significantly longer left renal veins also drain into the inferior vena cava, the left crossing anterior to the aorta but posterior to the superior mesenteric artery. The right gonadal and right suprarenal veins normally drain into the inferior vena cava, while the left gonadal and left suprarenal veins usually drain into the left renal vein. The inferior phrenic veins normally drain into the inferior vena cava as well. The viscera associated with the posterior abdominal wall are the bilateral kidneys and suprarenal or adrenal glands. Unlike the viscera of the abdominal cavity, which developed intraperitoneally, such as the digestive tract and the liver, the kidneys and the adrenal glands develop posterior to the peritoneum, never possess a mesentery, and are covered by peritoneum only on their anterior sides for the entire course of their development. The kidneys and adrenal glands are thus classified as primary, or primarily, retroperitoneal organs. You're probably aware that the word renal refers to the kidneys, so, as you might imagine, the suprarenal glands are located just superior to the kidneys. The kidney is responsible for regulation of fluid and electrolyte balance. The functional unit of the kidney is the nephron, which consists of a ball-shaped glomerulus partially encircled by a cup-shaped glomerular capsule, or Bowman's capsule, that is connected to a renal tubule. The glomerulus consists of a dense concentration of capillaries. The blood flowing through these capillaries is under such high pressure that some of the fluid from the blood is forced out of the capillaries. This fluid, called a filtrate, is received by the Bowman's capsule and passes through the three sections of the renal tubule, which are the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. Much of the water in the filtrate is returned to the interstitium and surrounding capillaries as it passes through the renal tubule. The remainder is delivered by the distal convoluted tubule to a collecting duct. The filtrate may be further concentrated as it passes through the collecting duct. When it reaches the distal end of the collecting duct, the filtrate is called urine. In a coronal section of the kidney, its tough fibrous capsule is thick enough to be distinguished from the underlying cortex, which surrounds the entire periphery of the kidney and extends deep into the organ to form renal or cortical columns. Between the renal columns are pyramidal segments of renal medulla. The cortex contains the glomeruli, Bowman's capsules, and the convoluted tubules, while the medullary pyramids are composed of the loops of Henle and the collecting ducts. The collecting ducts converge to form papillary ducts that end at the peak of the medullary pyramid, which is called the renal papilla. Urine is released from the papillary ducts at the renal papilla into another cup-like structure called a minor calyx. Minor calyces merge to form major calyces, which in turn merge to form the renal pelvis. The renal pelvis is the dilated origin of the ureter, a muscular tube that carries urine to the bladder. It is located in a space called the renal sinus that is occupied by fat, as well as by the vessels and nerves supplying the kidney. The hilum of the kidney, the area on the concave medial margin of the organ where structures enter and exit the kidney, may be considered the entrance to the renal sinus. The kidneys are located lateral to the bodies of the T12 to L3 vertebrae. The right kidney is usually located more inferiorly on the posterior wall than the right, perhaps due to its proximity to the liver, which is superior to it. The superior pole of the left kidney is found at about the level of rib 11, while that of the right kidney is at about the level of the intercostal space between ribs 11 and 12. The 12th rib therefore supplies some protection for the kidneys posteriorly. The ureters descend along the posterior abdominal wall, cross the anterior surfaces of the common iliac arteries at about the level of their bifurcations, cross the pelvic brim to enter the true pelvis, and proceed antero-inferiorly to the base of the bladder. They remain retroperitoneal on the posterior wall, and upon entering the true pelvis, become subperitoneal, that is, inferior to the peritoneum and not at all in contact with it. The kidney and suprarenal glands are surrounded by fat, which is sometimes called the perirenal fat capsule. Surrounding this fat capsule is a membranous sac of renal fascia. Surrounding the renal fascia is the extraperitoneal fat. The renal fascia sends extensions through the extraperitoneal fat to help hold the kidney in place. It also forms a septum between the kidney and the suprarenal gland, and anchors the suprarenal gland to the fascia of the overlying diaphragm. The right suprarenal gland has a pyramidal shape, while the left gland is crescentic. The two parts of the suprarenal gland, which are the peripheral cortex and the central medulla, have separate embryological origins. The cortex develops from cells that originate in the epithelial lining of the embryonic abdominal wall. Cells from the embryonic neural crest, which give rise to such structures as the sympathetic chain ganglia, migrate anteriorly and invade the adrenal cortex to form the adrenal medulla. The cortex converts cholesterol into steroids that include glucocorticoids like cortisol, mineralocorticoids like aldosterone, and androgens like testosterone. The cortex secretes these steroids into the bloodstream via the veins that drain the gland. The medulla is actually a portion of the sympathetic nervous system that functions like an endocrine gland. It uses the amino acid tyrosine to manufacture the neurotransmitters epinephrine and norepinephrine. Instead of releasing these neurotransmitters across a synapse, the medulla releases them into the bloodstream in response to physical or mental stress. Norepinephrine and epinephrine, which are classified as catecholamines, bind to adrenergic receptors on the plasma membranes of many cell types and cause sympathetic responses such as increased heart rate and pupillary dilation. The blood supply to the kidneys, ureters, and suprarenal glands is provided by branches of the abdominal aorta. The renal arteries normally branch from the lateral aspect of the abdominal aorta at about the level of the intervertebral disc between the first and second lumbar vertebra. During development, renal arteries form and regress along the aorta as the kidney's position on the posterior wall becomes more superior. When development is complete, there is usually just a single renal artery supplying each kidney. Occasionally, however, one or more of the inferior arteries fail to regress, and the adult kidney may have multiple arteries supplying it. There are usually several renal veins draining each kidney that merge to form the right and left renal veins, which drain into the inferior vena cava. The blood supply to the ureters may come from various sources along its length, including branches from the renal arteries, the gonadal arteries, the common iliac arteries, or direct branches from the aorta. Blood supply to the pelvic part of the ureters is provided by branches from the internal iliac arteries. The suprarenal glands, like most endocrine glands, receive an extensive blood supply. The inferior phrenic arteries usually give off several superior suprarenal arteries. The aorta provides one or more middle suprarenal arteries, and one or more inferior suprarenal arteries usually branch off of the renal arteries. One large right suprarenal vein usually drains into the inferior vena cava, while one large left suprarenal vein usually drains into the left renal vein. The preganglionic sympathetic nerves that innervate the kidney run in the least splanchnic nerve, which carries sympathetic fibers from the lateral horn of the gray matter at spinal cord level T12. These fibers synapse at the aortico-renal ganglia, which are found at the origins of the renal arteries. The postganglionic sympathetics follow the renal arteries to the kidneys. Parasympathetic innervation to the kidney is provided by the vagus nerve. The sympathetics are thought to be involved with vasoconstriction of the renal arteries, while the parasympathetics are vasodilators. Steroid secretion from the adrenal cortex is thought to occur in response to hormonal stimuli. There is evidence of neural control of this part of the gland as well, but it has not yet been well elucidated. Preganglionic sympathetic nerves that innervate the adrenal medulla are found in the greater splanchnic nerve. They pass through the celiac ganglia without synapsing and terminate directly on the chromaffin cells of the medulla, which respond to sympathetic innervation by releasing epinephrine and norepinephrine.
So that covers the posterior abdominal wall. Now I want you to pause the video and answer the end of session quiz questions, and then we're going to go through those answers together. All right, let's get started. First question, what's the motor nerve to the diaphragm and what are the ventral roots of this nerve? So the motor nerve to the diaphragm is the phrenic nerve, and that receives contributions from the ventral roots of C3, C4, and C5. So you can remember the mnemonic C3, 4, and 5 keep the diaphragm alive. Next, a positive right psoas sign could indicate pathology in which areas? So we talked about the one you want to know, the appendix. But you should also be aware that a positive psoas sign could indicate pathology of the kidney, the pancreas, the ureters, the cecum, or the nerves of the posterior abdominal wall. Next, which nerve roots give rise to the genitofemoral nerve, and which muscle does this nerve innervate? Well, the nerve roots are L1 and L2, and the muscle innervated is the cremaster muscle. Next, what are the three unpaired arteries off the abdominal aorta? So the three unpaired branches are the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. Next, what are the four sets of paired arteries off the abdominal aorta? So the paired branches of the abdominal aorta are the inferior phrenic arteries, which usually arise independently from the aorta, but they could be branches of the celiac trunk. You also have the renal arteries, the middle suprarenal arteries, and the gonadal arteries, which supply either the testes or the ovaries. And then finally, we have some images for you to label in a mock practical. So label those images, and then you'll be finished. Thanks.